Dr. Abhimanyu Sharma. Polymerase chain reaction in viral anti-uveitis with secondary glaucoma, analysis of 28 eyes. The first one is this one, Haryana. Okay, sorry. So the Haryana Ophthalmic Society, the first paper is Choroiditis, Diffusa, Acuta, and Unusual Diversion by Abhimanyu Sharma. Correct?
Yes, sir. May I start, sir?
Yeah, please start. So your timer is ready?
Yes, sir.
Excuse me? Yeah, you all are ready, no? Start. Yeah.
Okay, so this was the term used by Harada himself. Before he arrived, they arrived at the acronym of VKH. So we had a 29-year-old male, sudden onset diminution of vision in the right eye since the past 5 days. Visual acuity was finger counts at 1 meter, anterior segment was within normal limits. And he had a history of fever 4 days prior to the episode. And on examination of the posterior segment, we saw active vitritis, peripapillary subretinal fluid, hemorrhages, hypopigmental chorioretinal lesions, and premacular hemorrhage. So on OCT, we can see the SRF and we can see the heme. Left eye was significantly, it was doing okay. There was no significant findings. In hindsight, now we looked at it, they have a very subtle ILM fold and OCT was grossly normal. So we went into the differentials looking at, impending retinal vein occlusion, syphilis being the great mimicker, tuberculosis, Valsalva retinopathy, and blast crisis. So we order a battery of tests that include your blood counts, treponemal antibodies, your gold standard, Montox, and the entire panel. So 4 days later, he comes to us. Now the left eye, the visual acuity is dropped to 624. We have parafoveal choroiditic lesions, neurosensory detachments, subretinal fluids, and active vitritis. So we do an FFA, we can see some early pinpoint leaks, right, and late pooling in the disc and hyperfluorescence in both the eyes, which was seen. And on ICGA, we saw hypersenescent vessels and multiple hyposenescent dark dots. And these were the fuzzy vessels which were seen in the peripheries. So an working diagnosis of VKH was established, and oral steroid therapy with 60 milligrams of methylprednisolone was started. So the patient was on recovery 4 weeks post oral steroid therapy. The left eye recovered to 6.6 and N6. But the right eye, we had a visual acuity of N6 by 36 and 18, and there was sub-ILM heme. So we advise that you go in for a right eye vitrectomy with ILM peeling and sub-ILM heme removal. So this is the video of the surgery. So we stain the ILM. ILM becomes very tenacious here when there's blood underneath. So this is 3 weeks post-op, the right eye. He's doing pretty good now. He's 6 by 6 parts. With correction, he's 6.6 now. And key points I would like to point out in this case is that it's extremely important to rule out systemic conditions. We have to use the diagnostic modalities here. At the first go, we did not think of using FFA and ICGA. It was only done later on. And immunosuppressive therapy, we have to combine it with azathioprine and cyclo and CPs, because the patient just came back to us recently with the same symptoms again, and surgical intervention whenever it's necessary has to be taken. Thank you.
So why do you think was the hemorrhage in this patient in this one eye?
Sir, so there were two theories which we came to. Number one was that there was a very strong perivascular adhesion with the vessel. So we aren't really sure about it. The second one was that there might be a vascular anomaly. We did do an Octa for it. I don't have the images for that. So, but because he was already operated, we couldn't actually trace the anomaly. So these are the two theories which we could come down to.
And in the eye, which is weakage, there's so much of inflammation. When you're going inside, the retina can be very friable,
Yes,
you know.
absolutely,
So I think
sir.
you have to. Why didn't you do a solumedrol? I was wondering in this patient if that's such severe weakage. I was wondering.
So it was the first. It was the first attack. That's why probably.
So you waited for the inflammation to totally
yes,
subside, and then you
four,
went. So
4 to 6, fifth week we operated
week,
him, sir, with steroids.
Very nice case. Yeah, I think it's very nice and nicely documented case.
Thank you.
Just one question. For azathioprine, what are the prerequisites in your institute?
So, ma'am, usually in my institute, we don't start it at the first go. We obviously start with the steroid. It can go up to 6 months as well. Some people do that. But I think so in LFT and KFT, before starting the azathioprine is a must.
Do you get a genetic evaluation done or just keep a close follow-up?
In our institute, we don't do that usually, but I think so it should be done.
Should be done. Do you do that?
I don't do in my case, but I just follow up with the blood count.
Yeah, blood
routinely.
count is absolutely.
That's the most important thing in
LFT, KFT
azathioprine.
and the blood
Yeah,
count,
yeah.
has to be done.
A very interesting case. And how do you follow up such patients? What is your protocol for that?
So, ma'am, usually we look at them at every 3 to 4 weeks. Like the surgical eye, once it's done, 3 to 4 weeks has to be taken into account. And initially, when we are treating them for acute cases, 2 weeks has to be followed up. The patient has to follow up every 2 weeks.
With your regular blood count also to be
Yes,
taken
yes.
consideration. Right.
We can go on to the next.
Good. Next, I think yours presenting the next one.
No, sir. There's a confusion in the.
So next.
Polymerase chain reaction.
Okay. Yeah. So, okay. So yeah.